Thank you, Mark. We have another Toronto product for the last talk. R.J. Cusimano is going to tell us about a hot topic, tumors with valve involvement. So a little bit of oncology.
That's right.
Sounds bad.
This is something different. Thank you very much to the organizers for allowing me to speak today, and it's a real honor and pleasure to speak for Tirone. He's been my father. I've known him since he came back from France back in 1978, so we go back a long time. I was a high school student. Anyway, today the objectives are to demonstrate how little we really know about tumors, even the most common tumors we know, myxoma and fibroblastoma, how little we really know about them, and to develop a rational approach to a patient with tumors that affect the valves of the heart. So I'm starting with a papillary fibroblastoma. This patient has obviously multiple fibroblastomas. How many people would operate on this patient? Most people would, yeah. She's seen me for 13 years. She hasn't had any problems. It's found incidentally, and she never wants an operation. She just wants to come and visit me and say hello every year. Now, how do we get this notion of operating on a fibroblastoma? Well, it comes from this paper from Mayo Clinic. For over 15 years, they did 575,000 echoes and found 511 patients who had fibroblastomas. The paper doesn't tell us why they had the echoes, but they found these fibroblastomas, 511 of them. These were not small tumors. They were an average of 8 to 20 millimeters in diameter, but they operated on 185 of these. 94 had isolated operations or operations for isolated fibroblastomas. And they sort of concluded, well, you know, those were our best results. We had very good results, so if it's on the left side, it might embolize. Why don't we just operate in them? And that's where this notion comes from, that we have to operate on fibroblastomas. There's no real evidence that they really do embolize after you find them, just like that lady. Here's another one, myxoma. Myxomas are, everybody knows about myxomas. And this paper, again out of the Mayo Clinic, took 56 years to find 194 patients. 56 years to get 200 myxomas. And from that, they tell us that the natural history of myxomas equals that of the standard population, what you operate on them. Is that true? Who knows? 194 patients. We're working on an initiative called the Interact Project, where we're trying to get all tumors around the world integrated so we can answer some of these questions with a little bit more science. It's not working. I'm going to concentrate on this talk on the tricuspid valve. I'm going to show 4 cases, and I want you all to look at these, figure out what you think it might be, and what you would do for these particular patients. So this is the first patient. Obviously, it's all tricuspid valve. Here's the second patient. First patient had dyspnea, presented with dyspnea. This patient collapsed, had a syncopal episode, and you can see the tricuspid inflows being occluded by this tumor. Here's the third patient. This patient presented with cardiogenic shock, progressive hypotension and cardiogenic shock by the time we operated. And here's the fourth patient. It's not an echo, but it's obvious to see a very, very large tumor that affects both the tricuspid valve and the rest of the right atrium. So what you really want to know is, what is it? Well, if it's benign, it's either a vegetation, thrombus, fibroblastoma, or myxoma. Those are the 4 most common entities. If it's a malignant tumor, you want to know if it's primarily a tumor of the heart, or if it's metastatic to the heart, or if it's adjacent structure that affects the heart secondarily. The imaging you're going to use is echo, and if you have an echo, and you should always get an echo in any cardiac tumor, ask for contrast, because contrast demonstrates whether there's any uptake or vascularization of the mass. CT scan will be very good at localizing the tumor within the heart, but MRI gives you tissue characteristics. PET scanning is good because it tells you metabolic activity. It doesn't necessarily mean it's malignant. Some myxomas do uptake the FGD. Cardiac catheterization should be performed in everybody, regardless of age, if you're going to resect anything other than an atrial septum. So it's important for planning the operation. What gives you a hint that it's a benign tumor? They're in usual locations, the intraatrial septum for myxoma. It's important that it's in the usual location for these tumors. They often have no flow, and if there's no flow within the tumor, in other words, no uptake by contrast, it's either a thrombus or a vegetation. They don't invade structures. Benign tumors don't invade the structures. They don't grow fast, and they're often very silent until they get very large, or obviously if they embolize. So these are the things that tell you that it might be benign. So this patient had no uptake on echo, on contrast, by contrast, or an MRI, so this was a thrombus. And this is what it looks like in the operating room. This patient had thrombocytosis. This patient had attachment only to the intra-aortic septum, nothing else either in the heart or outside the heart in the body. And this was a myxoma, as you might expect. You can see the intra-aortic septum bouncing back and forth. In fact, you can see it separating from the rest of the heart there. This is purely a myxoma. Now, what about malignant tumors? Malignant tumors of the heart are in unusual locations. So a myxoma in an unusual location may not be a myxoma. So look for unusual locations. They're solid, they're immobile. They don't move around like a myxoma moves. And importantly, anything that transgresses natural barriers may very well be malignant. They may be multifocal inside the heart. It's unusual to have benign tumors that are multifocal, except if you have Carney's complex. And they metastasize, obviously, and the patient may already have cancer. Just because they have cancer doesn't necessarily mean it's a malignant lesion inside the heart, but it gives you an idea. And they make themselves known very quickly. They're not silent within the heart. They will make themselves known very quickly, perhaps because they grow so rapidly. So this is a solid tumor. You see how solid it is. It doesn't move around, doesn't wiggle around like a myxoma normally does. And you can see that it invades the intra-atrial septum. It goes into the left atrium. So this was a sarcoma. It's actually a metastasis to the intra-atrial septum, which they had noticed a few weeks before that had grown over the next few weeks. The natural history of a sarcoma of the heart without treatment is 1 month survival. So they grow very rapidly. This you can see is very extensive within the heart, and you see it invades the heart. You see by the right atrial groove there, it goes through the heart. And so this was a sarcoma. Whenever we talk about tumor resections, as was mentioned, we have to talk about oncology. Most of the people here have some training in thoracic surgery. We have to talk about R0, which means a complete resection. Your specimen doesn't have any microscopically positive margins. R1 means they're microscopic residual disease. The pathologist tells you it's good, but the margin is affected. That's called R1. You don't see it, but the pathologist does. R2 is obvious residual tumor, and that means debulking. You want a goal as an R0. Most tumor resections are R1 because people underestimate how far the endothelial extent of that tumor is. And R2 or debulking is not a good idea. This was one little experience. Again, 17 years to amass 29 patients. Tumors are very rare. Malignant tumors are even more rare. But you can see the best outcome there was an R0 resection when microscopic was negative. R1, microscopically positive, equal the survival of a debulking tumor. It's not good to have any tumor left behind. This is a case of the one that I did a number of years ago. She's still alive, but the patient came in cardiogenic shock. You see most of the right ventricle was full of disease. It was a sarcoma. The tricuspid valve was also involved. I did a debulking tumor. You can see on the other picture it went through the heart. I resected part of the heart, debulked it, removed the tricuspid valve, and replaced it. 2 weeks later, I got a baseline MRI for the oncologist because she obviously needs more treatment. You can see about 2/3 of it within 16 days was back. If you debulk a tumor, it's going to grow back and will kill the patient before the sternum is healed. The survival without any further treatment of a debulking procedure equals that of the natural equals that if you had not operated at the beginning. But if there is time, you should biopsy. We recommend transvenous biopsy. The heart transplant people can do this, the cardiologists. If you can't get that, in Toronto, we've started doing percutaneous biopsies of cardiac tumors. Dr. Rogala is one of our interventional radiologists, and he's able to do this. I was a little bit surprised first time I asked him, but he gets great core biopsies. We have very little problems with it, and we presented our first 20 cases about a year or two ago. If you do find the pathology, in this particular case this was a sarcoma, you give them chemotherapy, and the idea is to shrink it down. You can see the final result is that of a much smaller tumor, but it still affects the tricuspid valve. So this person will have an operation. You can see in the operating room the tumor transgressed the heart, one of those things that I spoke about, and it also transgresses both the ventricle and the atrium. So we have to deal with both. You can't just deal with one. These are large operations. You can see the specimen involved the ventricle quite a way out. About the same amount of ventricle was removed as atrium, and the atrium was removed from SVC to IVC. You can see in the middle picture the two black spots. It's still active tumor. You have a huge amount of tumor kill. You can remember how big it was before. Some of that's scar, some of it's active tumor. You don't know where the active tumor stops and the scar starts. That's why you have to remove everything. And that's why an R1 resection is a very common thing with cardiac resections. You see the ventricular aspect, it looks fine, but an external exam, you don't know whether there's tumor there or not, so it has to be resected. is what you're left with, a great big hole in the ventricle. And it's surprising how much right ventricle you can remove when you remove these tumors. You have to remove both the SVC and the IVC in order to get an R0 resection. Once you have that out, you have a hole in the diaphragm. You take a large Dacron graft. I use a Dacron graft. I don't use ringed Gore-Tex. I just use a Dacron graft. And resect from the, replace it from the diaphragm, suture it onto the diaphragm, and suture it onto the SVC as high as you can go. The ventricle, believe it or not, takes sutures really quite well for a valve. So you can put them through the ventricle. And again, you can go really far into the ventricle, a lot farther than you think, and it seems to work well. So once you have the graft, suture the replacement of the SVC to IVC, and the valve put in there, you make a fenestration in the graft, so the medial aspect onto the heart, and you take a piece of bovine pericardium and you complete the resection in order to give you a neo-atrium. You can see there the SVC and the IVC are completely resected, and that's to try to get an R0 resection. It's important to remove the IVC and SVC in these cases when you do right-sided tumor in order to try to get that goal of getting an R0. It's important also to make the RA as redundant as possible. We heard this morning about the atrium doesn't really add any contractile reserve. It's really a capacitor. And if you make this too small, some people will get peripheral edema. So you have to have a large, capacious right atrium. But again, you can see how far over the right atrial resection was. Many times you have to do a coronary bypass. That's why you have to know if that acute marginal is a large one, an unimportant one, et cetera. So what about the difference between a primary? Remember I said if it's a malignant lesion, you need to know whether it's a primary or whether it's a metastatic lesion. What are the issues? Well, for the primary isolated cardiac tumor, the endocardial spread is really very, very extensive, and there's really risk of having an R1 resection. It needs a much, much more extensive resection than a metastatic lesion. Metastatic lesions, there's two different types. One is a metastatic lesion to the heart. That has a better R0 because remember, that tumor has gone and seeded itself into the heart and is growing and pushing away the myocardial fibers of the heart. So the chances of you getting an R1 are much less if it's a metastatic lesion to the heart. But you do have other lesions to worry about. Tumors from the heart, in other words, starting in the heart going elsewhere, are widespread. People say the right-sided lesions, you don't have to look at the brain, always look at the brain. Always look elsewhere because malignant tumors of the heart, primary malignant tumors of the heart, are very, very notorious for metastatic disease, and they're very dangerous. So in summary then, not much is known about tumors, even very common ones. We base our data on very, very small numbers, even the common benign tumors. Typical tumors in typical locations are likely what they seem, but beware of tumors in unusual places because they may be very bad. So you look for vascularization of the tumor, look for metastatic deposits, try to biopsy it first, and these are very, very aggressive operations. David Adams left. I was asking him about a biological valve before. There's no place for a mechanical valve in tumor surgery. There's no place for a repair of any valves. You have to remove it because the mechanical valves the patient will not outlive a biological valve with what we know today. And repair, you have to be careful with that because you're going to be stuck with an R1 resection, and you know the outcome of an R1 compared to R0 and compared to metastatic disease. And please ask for help. You can contact me, anybody who wants some help about these sorts of things. Thank you very much.
Thanks, RJ. Stay up, I've got good questions.